whole healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Leaders in Healthcare. I'm Dr. Jordan Vollrath, physician, entrepreneur, and Chief Medical Officer for Cherry Health. We're talking about all things healthcare. Join us as we speak to innovators, industry leaders, and the people working to drive the healthcare system forward. All right, today we're talking to Bill Thole. I recently met Bill in Montreal at the Canadian Conference for Physician Leadership, where he was easily one of the best speakers I've had the pleasure of listening to. Bill is an associate professor at McMaster University and an officer of the Order of Canada. He has co-written 2 health leadership textbooks and worked with Monique Bégin to help draft the original Canada Health Act in 1984. And today we're talking about that exact piece of legislation, the Canada Health Act. Bill, thank you for joining us.
Oh, it's a real pleasure, Jordan. Looking forward to
it. So before we get into the Canada Health Act, I got to know, what was it like being put into the Order of Canada? And for anybody who's not familiar with this is like the equivalent of being knighted. That had to have been pretty special.
Well, I just came back from Saskatchewan, and certainly my mom was pretty impressed with that. And it did come. It's supposed to come as a surprise, and in fact, it really did not come as a surprise. I can remember my wife getting a call on our deck, and she said, "Bill, there's the Governor General's office is calling you." And I said, "So what kind of trouble am I in?" She says, "I don't know." And so they let me know that I had received the Officer of the Order of Canada appointment. But then they said, you can't tell anybody for 2 months. That's hard.
It's a tough one to sit on.
It's tough to sit on that for 2 months until they actually announce it. But boy, it's nice actually to be acknowledged and have stuff that I've been involved with acknowledged, including the work I did with Madame Bégin way back in 1983, 1984. So thanks for asking.
Very cool. Well, tell me more about how things went back then. So you're tasked with coming up with the Canada Health Act. I guess, what was life like before that? I'm picturing people just walking around with open sores and leprosy and their limbs falling off, but maybe that's a little too far in the past.
Well, okay, so the Canada Health Act actually we started talking about it. I was with Health and Welfare Canada at the time. I was with the Health Policy Division of Health and Welfare Canada. And early discussions on the Canada Health Act started at or about the same time as the federal government moved to block funding of provincial health insurance programs in 1977. So we talked about it in 77, 79. Then, of course, we had the 9-month Joe Clark government, during which time we had the first of what ended up being 3 SOS Medicare conferences that Monique Bégin in opposition led. And then when she was reappointed, and it was almost an accidental government, right? Pierre Elliott Trudeau had taken his walk in the snow. He'd resigned, and then they had this really short term with Joe Clark, and then Trudeau the Elder came back and reappointed Monique as the Minister of Health and Welfare. All of a sudden, and things are kind of going along very, very slowly, until I get a call in October of 1983 from the minister's office saying she wants to form a small team because she's not getting anywhere with the formal bureaucracy. The provincial deputies were saying, we don't need a Canada Health Act. Premiers were saying, we don't need a Canada Health Act. And the record will show that every province in the country and every territory in the country, for the exception of Manitoba, opposed the Canada Health Act. Don't need it. So she put together this small team. She called us the Trois Mousquetaires, the 3 Musketeers. And it was our job to put the Canada Health Act together. And that happened in a very short period of time, actually, between October of 1983 and April 17th, when it received royal assent. And I was, I think, 32 years old, and I was about 3 layers down in the bureaucracy. So getting a call at 5:30 in the afternoon, sort of from the minister's office saying, "Would you join this team?" That was pretty cool. That was pretty cool. And then it was very intensive, and along the way, along the way, cabinet was not of one mind on this. Ministers like Alan McEachen were saying, do we really need to provoke the provinces, especially Quebec? Remember, Quebec in that 1983-84 had a separatist government. And people like Marc Lalonde were not on board.
Did they have reason why? Like, what was the opposition for?
No, but there was a political judgment call, right? And it was near the end of the mandate, the waning days of the Trudeau government. And so, do we want to? And they were worried about this guy by the name of Brian Mulroney. And so in many ways, the Canada Health Act was a bit of a Hail Mary pass, trying to provoke the Conservatives to vote against it. And the Prime Minister at the time was not, and Monique talks about this in her book, was not necessarily prepared to kind of use up whatever residual political capital he had on this file, until we actually prepared a MAMA chart, a stoplight chart with all the 22 sections of the Canada Health Act, clauses of the Canada Health Act on the vertical, and all of the different representatives or representations on the horizontal, where you had all the provinces, the CMA, the Canadian Nurses Association, the Canadian Labour Congress, all of these different advocacy groups. And if you can imagine this stoplight, every cell had a red dot, a yellow dot, or a green dot to signify whether they were against that provision of the Act, were okay with it, or dead set against it. Red, yellow, green if they were in favor of it. Of course, it was a sea of red, as I just indicated, for the provinces, except for Manitoba, which was yellow and green. It was a sea of red for the Canadian Medical Association and all the medical associations. And your viewers might want to know that for 8 years I was CEO of the Canadian Medical Association. You might want to cycle back to that. How is it that a non-physician gets appointed to be the CEO of the Canadian Medical Association, having helped write the Canada Health Act? Think about that for just a second, right? Anyway,
fresh eyes from the outside.
The chart continues on until you see the Canadian Labour Congress, the Canadian Nurses Association, the Consumers Association of Canada, all of these, it was green, 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 green. So the Prime Minister said to Monique, let me understand this. All the provinces in Canada except Manitoba are against this, right? Right. All the doctors of Canada are against this Canada Health Act. Right? Right. But the people of Canada need it and want it. Right. Well, we're going to do it then. That's leadership.
Bold. Yeah.
That's leadership, right? Doing the right thing at the right time for all the right reasons.
Might not be the most popular move, but necessary.
Well, in the event, what happened was the Conservatives voted for it. It was passed unanimously in the House of Commons. And that fall, Brian Mulroney roared to a majority government.
What were the criteria, I guess, or when you sit down to draft such a substantial piece of legislation? What's the...
Well, we didn't start from scratch, of course. It was an act to repeal and replace the original Hospital Insurance Diagnostic Services Act of 1957 and the Medicare Act of 1966, 1968. So we started with these two, and they were very closely aligned except for one provision, and that was the accessibility criteria. And that was the one that was, if you ask why, what created that, the forces that resulted in Canada, it was extra billing and user fees bubbling up to the point where I can remember one study that we quoted had 100% of the obstetricians and gynecologists in Peterborough were opted out and significantly extra billing all the patients, right? Making it very difficult for, poor women and women from poor families to access necessary services. So it was studies like that, and it was probably only no more than 5 or 10% of physicians at the time were extra billing, but it was very concentrated in particular areas. And so that was the provocation, but we didn't start from scratch. We put the two acts together, and then we really ramped up the accessibility criterion. What was at the time, what were medically necessary services, what were insured hospital services, And so it wasn't from scratch. It was an act to repeal and replace the original two pieces of legislation.
This show is brought to you by Cherry Health, Canada's medical network where healthcare practitioners connect. Physicians, pharmacists, nurses, chiropractors, and all other healthcare professionals can sign up for free, start connecting, messaging with colleagues, or checking out job opportunities posted by thousands of employers across Canada. With dozens of healthcare-specific job filters and search options, we make it easy to advance your career, find your dream job, or line up your next locum with hundreds of new jobs posted every week. www.cherry.health to get connected today. And at that time, what was, I guess, the biggest challenge for Canadian healthcare, right? I guess in today's day and age, we might still say access. Was this the same back then, perhaps for different reasons?
Well, access was certainly, as I just said, with extra billing and user fees. The evidence at the time and still to this day suggests that that's a deterrent for only the poorest Canadians and the elderly, right? And so if you want to address that, you have to address point of service charges. And so we did that, knowing that the federal government can't dictate to the provinces, but we made it revenue neutral, right? If you raise $1 in user fees, you're going to have $1 deducted from the federal cash payments, right? So that was one of the main things. The other one was portability. People like me, we see portability as the glue and the grease that helps it's what makes our system Canadian, right? Every province does their own thing to some extent, but there's a core agreement on the minimum basket of insured services. So then when I go to visit you in Calgary, or more often my wife and I go to Vancouver to visit our grandkids, it's nice to know my OHIP card is as good in Vancouver as it is here in Ottawa.
We got all this land. You got to be out there enjoying it, right?
And so that's not easily done. So the things that happen behind the scenes to make the system work, there's this group that meets regularly, the Eligibility and Portability Committee. And there's a Lee guy that convenes them at Health Canada, and he's been there for 20 years. And there's all of these negotiations behind the scenes as to what is eligible in this shared basket of services. And that's what really makes the Canadian system allows us to talk about a Canadian system. And so for those who increasingly see Canada Health Act as a problem, let's just rip it up. It's 40 years old, this old house, it's time to demolish it rather than rebuild it. I say to them, do you value going to Vancouver or wherever your family might reside? I just came back from Saskatchewan, the home of Medicare. My card is as good there as it is here. So if we rip up the Canada Health Act today, are you prepared to pay what, $2,000, $3,000, $4,000 for supplementary health insurance to visit other parts of Canada, like you'd have to do now to visit the United States or any other part of the world? And then people sort of say, "Oh, I didn't realize that that's what the Canada Health Act does, is allow us that kind of portability." Or when economists like me, and that's my training, I'm an economist, you look at what's going to get in the way of labor mobility, people moving from one province to another to seek jobs. Well, one of the things that people don't talk about is this portability provision. There's a 3-month waiting period. If Jordan moves here to Ontario, Alberta covers you for 3 months until you get settled here and you apply for residency status here. And in the meantime, you're covered. Imagine what it would be like if you didn't have that. You'd have what they call in the United States job block? Anyway, the fact is that you get stuck in a job and you can't get out of the job to go to a better job because your insurance won't follow you.
Well, it seems like maybe a small thing, but like the consequences of not having that in place are huge. If you move Precisely. And then something happens, right. Oops, there goes everything.
Well, and people take it for granted, and it can't be taken for granted, right? These dedicated public servants. We like to. I'm a recovering public servant, so I really appreciate all the efforts that all these things they do that we never see, that help keep the glue, keep this portability provision working. And of course, the one exception of that, for those that might be watching from Quebec, is Quebec is the only one that's a non-signatory when it comes to reimbursement of physician fees. And Jordan might ask, well, why is that? Well, historically,
Why is that, Bill? Please do tell.
Historically, Quebec has paid its doctors 20 to 25% less in terms of their fee schedule than family docs and specialists in other provinces. And that is only as a consequence of if you have to go back to the October crisis of 1970, when they had separate negotiations. They created two separate unions, like Alberta Medical Association is representative of all doctors, specialists, and family docs in Alberta. Not so in Quebec. They have the Fédération des Omnipraticiens, the GPs, the family docs, and the Fédération des Spécialistes, the specialists. And they negotiate separately and off-cycle. So that this has enabled the Quebec government to get away, up until very recently, with paying doctors in Quebec less than every place else, which is why they didn't want to sign on to this reciprocal agreement where their doctors would end up having to provide services and get reimbursed at the host province rate, the Ontario rate, rather than the Quebec rate.
Fascinating. So just a fragmented negotiating team, but
Right.
behind that, budget, again, is the reason, as with all other things, it seems. What about in hindsight? Like, let's say if you could go back with your 2024 knowledge, transport back in time, what would you do differently with the Canadian Health Act and its intentions at the day?
Well, I thought about this a little bit. We probably wouldn't. We should have pushed back more on the constitutional lawyers, who were always worried about the federal government going a little too far and provoking a constitutional challenge. We have to respect the Constitution, but we also have to push the Constitution to its limits, especially when it comes to things as important as health and health. So I think we could have done. I'll give you one example that really bothers me, and that is the lawyers told us we couldn't include freestanding mental health facilities as insured hospital services. And the reason was that the federal government hadn't put any money toward either building mental health facilities or paying their operating expenses. So with no fiscal spending authority, they said, no, you can't put it in there. So I was a volunteer at the Royal Ottawa Hospital here in Ottawa, 9 years on it. And that's a tertiary, quaternary mental health facility. And it's technically not part of the Canada Health Act. So we should have pushed back on that and said, come on. Mental health is just as important as physical health, and we can't go excluding mental health facilities. Second, there's three that I'm going to mention. That's the first. Deal with some of these anachronisms. We could have dealt with them then, and it's never too late. We need to deal with them now. The second one is we should have had more accountability in there. The federal government transfers $50 billion to the provinces. Of course, it's never enough. They just met in Halifax a little while ago, said, give us more money and stay in your own lane, right? And we can maybe come back to what that means. But, it's the federal taxpayers need to know that the money didn't go to, buck a beer here in Ontario or writing off license plate registrations and other kinds of things. And it's not like I'm suggesting that we put a federal dollar sign on cash and track it around. It's just there needs to be more accountability. And it's not just accountability back to the taxpayers of Alberta, these bilateral agreements that have recently been signed. It's back to the federal taxpayer. The federal government's the one that takes the political heat in getting the money. And then when you're transferring it, it can't be checkbook federalism. Write a check and just do whatever you want with it, right? The second thing that we could have done differently is to explicitly have an accountability provision built in as a condition, not necessarily a criterion. 5 criteria, 2 conditions that can't help it. This would have been a third condition. And the third thing that we could have done and should have done, and again, it's not too late, is to give Health and Welfare Canada, now Health Canada, investigatory powers. Right now, you know what they rely on to determine whether provinces are abiding by the Canada Health Act? Press releases. The news. Can you imagine? How about 1888 CHA helpline? so that if Jordan, as a patient, has a concern about what's being covered or not, they can go to this hotline. Yes, that would create pressure on the federal government. But as long as they had the tools to deal with those calls, i.e. the investigatory authority to say, is this true? So that's pushing the envelope. That might provoke, a constitutional challenge from your premier, maybe invocation of the special provisions for opting out of the Constitution. I don't know, but it would be worth trying to at least have a conversation. So those are the three things that, with the benefit of the retroscope, I would have liked to have seen done way back in 1984.
It's hard to imagine a system functioning without accountability and the ability to investigate things for so long. And yeah, just recently, the transfer payments are now coming with the strings attached on them, which it sounds like you think partly gets at the root of the problem. But to make it through that many decades of operation without what you would otherwise, I don't know, if you're doing any spending in a business, a big one or a small one, I mean, that accountability would be the key to the money going anywhere.
Well, to your point about the bilateral agreements having some strings attached with it, I agree with that. Problem with that is that those bilateral agreements have only one-time only money, right? It's not built into the Canada Health transfer, the base. And
so you don't get a feedback loop, I guess.
Well, no,
it's just a report.
If I'm a province, and let's take the example of mental health. There was 2 iterations ago. At one of the first ministers' accords, they I think it was $11 billion, $6 billion of which was to home care, $5 billion of which over a period of time, I think it was 10 years, is for mental health. Well, if I'm a province, and that's only $500 million, by the way, per year, and then you divide that into provinces, that's not enough money for me to significantly invest in mental health, especially when I know that the money is not renewable. It runs out after 10 years. So these need to be, if you're going to make a serious impact nationally with national standards, so that you get the same. Another favorite example is: does anybody in this country not think that we should be covering out of hospital psychological services? Like,
you'd probably be pretty hard pressed to find somebody who disagrees. Yeah,
right. So why don't we put that in there and put permanent money rather than temporary money into the base, so the provinces can rest assured that the money will be there longer term, as opposed to have to renegotiate it after 10 years with a new government, right? That may or may not have the same view as the old government, right?
Yeah, they might agree. They might think something different completely.
Right. So those bilateral agreements are a good start, but they need to be accompanied by a permanent enrichment of the base, the CHT base, which is I think about $49 billion now. That needs to be added to the base and then escalated year over year by the rate of growth of GDP, which is an indicator of our growth in wealth.
That makes complete sense. What was the, public sentiment when it came to mental health back then? It's definitely become in vogue as of late.
Well, we didn't know what we didn't know. For those that follow this, we didn't have the Kirby report where we found that 1 in 3 Canadians are directly or indirectly affected by serious mental health issues. We didn't know, we didn't have the Mental Health Commission of Canada doing research. We didn't have a dedicated Canadian Institutes of Health Research pipeline for funding mental health research. Some people have remarked we were, even today, in terms of understanding mental health, and dedicating the amount of research necessary to better understand it. We're today with mental health where we were with cancer 30 years ago. But we didn't know what we didn't know. So, and a lot of people say, how come that wasn't in the Canada Health Act? Well, it was in the shadows. The title of the Kirby report was Out of the Shadows Forever, right? So mental health was still stuff you didn't really want to talk about, or still stigmatized. And so, but here's a key point, Jordan. There's none of us who were involved in the Canada Health Act, including Madam Beja, who thought it would last 40 months, let alone 40 years, without a single amendment.
This was one of the most interesting things when we were having the small group breakout sessions at the Canadian Conference on Physician Leadership, and we're looking up to all these Scandinavian countries as to how they model their systems and what are the parallels and the difference here. And then that was one of the things that you noted was like they modify theirs all the time. Like there's just constant updates and amendments coming to it versus ours is the gospel is just set in stone and thou shalt not even dare change anything with it.
Yeah, well, there's an Angus Reid poll that was done about a year ago, and it found that 38% of Canadians are purists. And what do you mean by that? Well, it's like the Canada Health Act came down from Mount Sinai, the Ten Commandments, and Madame Bejan was the equivalent of Moses. You can't change a word. And then there's about 30%, I think it's 28%, that are pragmatists. Okay, and I would count myself as a pragmatist. Like, okay, the Canada Health Act takes us so far. The publicly financed healthcare system takes us so far. Maybe we need to look at, the Royal Ottawa Hospital is a perfect example of a 3P when it comes to capital expenditures, public-private partnership, right? In its building and its construction and so on. Maybe we need to take a better look at that. But here's the concern I have. There's 28% of Canadians have basically given up on Medicare. I'm okay. I hope you're okay. But and maybe I'm going too far here, but is it an indicator of the decline of communitarianism and the rise of individualism? I suspect everybody that's listening to this knows somebody who got tired of waiting for their hip surgery or cancer therapy and hopped on a plane and paid out of pocket. Canadians are opting out of Medicare. We don't know how many. We don't know the rate at which it's increasing. And there's very few ways in which you can actually track it. Maybe with investigative powers, Health Canada might be able to get a better handle on, Canadians opting out of the system. But that's a concern. And it's one of the reasons why we need to, coming back to your point, look at what Europe's doing. Look at what Australia is doing. Why is it we've gone from top tercile in performing countries in the world to bottom tercile? I repeat that. In the last 20 years, and I can give you the data if you like, you look at the Organization for Economic Cooperation and Development, we've gone from top tercile, top third performing nations, whether it's access or perinatal mortality rates or infant mortality rates, we've gone from top third to bottom. Could it be because we have the most decentralized healthcare system in the industrialized world? Each province thinks it owns this piece of it. And nobody's stepping up. No provincial premier is stepping up and thinking about Canada. Even your home province, Peter Lougheed, back in the day, and even Ralph Klein back in the day, acknowledged that there was sort of room for a Canadian view of this, right? And just to take it a little bit further, as I thought about this, you ask, why is it we've gone from top tercile to bottom tercile? One of the reasons is we continue to pay hospitals on a block funding basis, right? Your
what does
hospitals
that mean?
It means you get a block of funds every year, and you negotiate, in your case, with Alberta Health Services, how much money you're going to get, and usually that's based on, among other things, patient volume. But once you've got that budget, every patient that comes through your door is a cost center. It's not a value center. You don't get paid more for more complicated cases coming in. And if you look at the way they're paid in most European countries, it's on an activity-based activity-based funding basis, so that each patient that comes through the door to your hospital, you get paid more, as opposed to each hospital takes money away from your block fund. Fee for service, you're a family doc. More and more younger physicians, do they really want to be business people? Do they really want to run a business and hire people? Or do they just want to practice good medicine and have somebody else worry about all that other stuff?
Some do, some don't. Some
yeah.
think they do, and then they try it out and realize they don't.
Well, good on the physicians that feel like they can run a business, but for those that don't want to run a business, we need to look at ways to help them out. And as a former CMA CEO, I think that the CMA needs to look at what it can do to help its members when it comes to some of these administrative issues, not just look to government all the time. But we do, again, coming back to, there's a lot of lessons to be learned from Europe, including how to pay physicians. Fee for service isn't the root of all evil, but it isn't the best way to pay for primary care. What you want to do is pay for better health rather than just paying $37, whatever it turns out per visit, irrespective of the complexity of the patient that's showing up at your office.
How do you actually? I find it interesting that you sort of speak favorably of the more fee-for-service model, because that's become just very unpopular in like recent media, right? It's like they're pushing away from it more to the complex care, the team-based model. But when it comes to the hospital side of things, do you think that would actually work better going back the other way then?
I do. I used to give talks when other countries would come to Canada and say, how is it that Canada spends so little and gets so much? And why is it that our administrative costs are just at 2.5% of total healthcare spending, and it's 12.5 or 17%? I don't know what it is now in the United States, but it's double digit. One of the answers I would give them is, well, we have block funding for hospitals. They don't have to track individual patients. They get paid whether they track them or not. Well, the downside of that is you can't track patients, and you have no idea what kinds of patients are coming in and out of your institution and how you can better manage that. So it might cost more administratively to track patients. And now we have EMR systems. We can all look forward to a day, hopefully soon, where there's interoperability of the EMR and EHRs, so that Epic talks to Cerner and Cerner talks to Meditech, and it becomes seamless, like our interact with my ATM card. But if that's the price of being able to better manage our hospitals and throughput and get patients reduced length of stay and all those kind of good things, and have discharge plans upon admission, and if that costs us just a teeny bit more, it'll save us a lot more on the other side, unnecessary readmissions and so forth.
Okay, so in favor of amendments to the Canada Health Act, what would the Canada Health Act 2.0 have different about it? Or what would some of those other pieces be that you think would help spruce it up and modernize our actual access to care?
Well, just to return to kind of this old house. So if this is an old house that's 40 years old, it's had multiple owners, and none of them have invested seriously in the foundation, which is pretty secure. Nobody that I've talked to, and the polling suggests nobody disputes the 5 criteria that we want: a comprehensive, accessible, publicly financed, affordable healthcare system for Canada. But maybe we need another foundational pillar, and that is the one I referred to earlier on: accountability. There's annual reports that provinces submit to Health Canada, and they're pretty performative. They need to be stepped up. We used to have a Canadian Health Council, Jean Chrétien's Accord of 2003, and coming out of the Romano Commission. There was a Canadian Health Council that worked for 10 years and was doing a pretty good job near the end of that 10 years, and then Harper killed it, put it out of it's subject to a 10-year review, and it was not renewed. And the reason it wasn't renewed is because it was doing a good job of comparing provinces and highlighting, leading practices and the need to scale and spread those leading practices. And of course, when you're comparing provinces on things like, let's say, infant mortality rates or average length of stay, there are going to be provinces that look really, really good, and there are going to be provinces that aren't going to look so good.
Yeah, no one wants to roll those dice and risk it.
And so the noisy ones were the ones at the bottom of that and said, hey, we don't need this Canada Health Council, but we need something like that. And maybe the Canadian Institute for Health Information, with a broad mandate, might be able to provide some indication of not just that the numbers are going up and down, but why they're going up and down, and how we can avoid what I call the NIH syndrome. And for those of you who have researchers, that doesn't stand for the National Institutes of Health. It stands for Not Invented Here syndrome. where Alberta feels it needs to, design its own primary care network. Or Ontario sees PCNs in Alberta working well, but we can't call them PCNs here in Ontario. It has to be something different, so we call them family health teams. And are they paid more or less the same per capita, as well as fee for service? Yeah, but we have to call them something different. So we need something there, stepped up way of making this natural experiment that we have in Canada, because it is a positive thing potentially having provinces each doing their own thing, and then some testing this not working, some testing that really works. But then we need to find ways for the stuff that works to spread it out, scale it, and spread it more quickly.
Is there a good argument against having added accountability? Like when they're actually in there on the floor debating these things, other than I don't want it because we don't want to get called out as being a low performer. That's not great for optics. Is there a valid argument against?
Well, there's an administrative cost that would be associated with collecting and analyzing these data. So I guess some would say, hey, our costs are already too high. The administrative burden is already too high. Why would we want to create another agency or another bureaucracy that, provides this kind of data? And then I guess the flip side of that is, if you don't know where you're going, any road will get you there, said Alice, or said the cat, the Cheshire cat to Alice. So if it's a plus and a minus for sure, and there would be arguments against it, as there were arguments that prevailed in the event of the Canadian Health Council.
Okay, so costs again, just like being proud of our low admin prices. We like that.
Right. And provincial autonomy, right? Constitutional authority for health and healthcare rests with the provinces. So, some here in Ottawa, we need to get the Medicare gum off our shoe, to quote one senior conservative leaders from some time ago. It's a provincial responsibility. We're never going to win a vote. As Joey Smallwood once said, I've never got a vote on healthcare, but I've certainly lost a few. So how do you make this happen in a political environment like Canada? And it'll take leadership. It'll take some significant and enduring leadership.
I mean, when it comes to the provincial autonomy side of things, I mean, it's interesting. You think that the economies of scale and just having it more centralized, things would be more streamlined, more efficient, more transferable, better defined processes. But then you look like here in Alberta, for example, just recently, Alberta Health Services is now splitting back up into its constituent components versus the opposite taking place of more centralization.
Well, restructuring, when you don't know what else to do, but you know that there's pressures to do something to change.
Hail Mary.
When in doubt, let's just restructure again. Let's Alberta's a perfect example of it. Like we're going to regionalize, and then we're going to have two regions, and then we're going to have one, and now we're going back to the zones and breaking up into the four elements that you're talking about. And again, you need to look at these things from a systems point of view, right? And you need to never get caught playing checkers in a game of chess. Like the forces of technology and the opportunities presented by technology are just huge. And to your point, I'm an economist, and I'm a health economist by training. So I would just point, we had a terrible series of events in Manitoba with respect to pediatric cardiac surgery. And there was a major inquiry. And what did we find out? That you need to perform at least, I think it was 200 open heart surgeries on kids to keep your skill level up. And there weren't enough kids in Manitoba to keep your skill level up. So what did we do? We created the Canadian, or the Prairie Network. I think it's still the case where all pediatric cardiac cases are referred to Edmonton, where you can have the critical mass, not just economies of scale. That's an economic argument. Critical mass of patients to keep your skill level. That's a quality of medical care issue, not an economic issue. We need to, and there's, Atlantic Canada is doing a better job now. They're no longer content with robbing Peter to pay Paul in terms of dealing with their physician shortages. They're starting to look at, well, they've actually got now reciprocal recognition of licenses in Atlantic Canada. We need to see that national licensure. We need to see that extended nationally in terms of recognizing national. There's no reason why Jordan shouldn't, if he's qualified to practice in Alberta, why he couldn't pick up and go to Northwestern Ontario if he wanted.
It was cool to see legislation like that coming out. I mean, these kinds of things I think are going to add up and make a big difference. So it'd be really neat to see how that plays out with that pan-provincial licensure.
Well, when all is said and done, said Aesop, more is said than done, and that certainly has applied historically to national licensure. But I actually do think it's going to happen. The Medical Council of Canada, I'm told, is this close, and the Federation of Medical Licensing Authorities are this close. Because they don't, naturally they want to stay in business at the provincial registrars, right? And they will still be in business in terms of dealing with, sort of complaints, right? But when it comes to licensing, they'll work together to ensure that, good doctors like Jordan are recognized across the country and can move.
Yeah, the portability should apply as a benefit to the providers too. I think we should be able to go there, come here. I mean, the argument that we'll lose all our doctors, right? Like if a couple papers and a few $100 of processing fee is the only thing keeping your doctor in your town or city, I think you've got bigger problems than whether or not the licensure is universal.
Correct. And again, coming back to my point about portability, you're quite right. There's an asymmetry, right? There's portability of insurance coverage, but there's not portability of licensure. So
even more so in Quebec with the PREM system, you're just locked right in.
Correct.
Yeah,
correct.
Well, okay. Let's say you have your magic wand. What would you do if you were in charge of the whole country for a day? Then what would that look like? You could pass whatever legislation you wanted. You got 24 beautiful hours.
Well, the one thing I wouldn't do is entertain this notion of what's called companion legislation. So, and you've got, I don't know whether the Senate has actually finally approved the pharmacare bill, but only two little parts to it. Diabetes drugs and
birth control, I think.
Birth control, yeah, birth control. Thank you. And then there's all this other stuff. And then you've got Dentacare, which is kind of a different way, the federal government going direct and paying. That's maybe something worthy of watching. But then you've got, the people worried about mental health and the fact that it's excluded from the Canada Health Act. They would want to have companion legislation, the Canadian Mental Health Act. Well, last time I heard from all the experts, the body and the mind are kind of connected pretty inextricably. Maybe we want to keep them together legislatively rather than have them separate. You've got a great minister for health, former minister for health, James Philpott, saying, well, maybe we need companion legislation for the primary care access, 6 million Canadians without, well, just a second here. The Canada Health Act was all about trying to improve access to, among other things, primary care. Why would you not look at ways and means to be more articulate in the Canada Health Act as to what's covered and what's not? So nurse practitioners. Did we think nurse practitioners might eventually be able to licensed to do what only doctors could do back in 1984? Of course we did. That's why we had the other healthcare practitioner amendment, where we allowed the provinces who do have the authority and the responsibility to license health professionals, but when they expand scope of practice into arenas that were typically physicians, should that be governed by the same extra billing provisions? Of course it should. So if I were to have a wand, I'd want to make the Canada Health Act more explicit as to what's covered and what's not. The comprehensiveness criterion needs to be updated. We need to get rid of the anachronisms like freestanding mental health facilities that aren't covered. Come on. We need to, put our money federally where our mouth is. So these one-offs need to be committed into the CHT base, so that the provinces can can be reassured that the money's going to be there longer term as opposed to short term. So these are some of the things. And these companion pieces of legislation, I call them orphans. The celebration around pharmacare. Well, pharmacare cleared the House of Commons, but the Conservatives voted against it. Unlike the Canada Health Act, where the Conservatives were on the record of voting for the Canada Health Act, the Conservatives are not on the record of voting for pharmacare. So fast forward a year from now, new government, $1.4 billion a year. Hey, there's a place where I can find some money right there. So those of us that are advocating for a Canada Health Act 2.0, and there's a paper that Greg Marshallton and I wrote it was subtitled Spring Forward or Fall Back. Come up with a CHA 2.0 by the spring of 2025, or get ready for those more constitutionalists. Let's get the Medicare gum off our shoe in the fall and turn the keys back over to the provinces. And we'll see how it hasn't worked terribly well, but maybe, hope springs eternal. Maybe it'll work better. But there is a window of opportunity politically to really entertain truly transformational changes that would put the Canadian back in Canadian healthcare.
What's the window of opportunity here? Instead of more commend or companion, adjunct pieces, how do we actually get to a point of revising or completely repealing and putting a new one?
So, not easy. Change leadership is not easy. Change management is easy. Cotter talks about the distinction between change leadership and change management very quickly. Change management, if you just Google Cotter, change leadership, change management, there's a 7-minute clip it's hilarious, really. He talks about I want you to imagine a Volkswagen, and healthcare managers are in this Volkswagen. They want to stick to the speed limit. They want to make sure they never even come close to the ditch, and they want to get from A to B, not necessarily quickly, but just get to A to B. Now I want you to imagine a leader. He's in a McLaren with a 1,000 horsepower engine, and they're interested in getting from here to there in a hurry. What do you need? You need a really good team. You need a good pit crew. You need a really good car. It's got and above all, you need a really good driver. So in terms of the first step in change leadership is to get is anybody in this country comfortable with where we are in terms of the Canadian healthcare system, that is performing as well? Is anybody content with the current state? And if not, can we have a clear vision for what that future state would look like? So let's take primary care. 6 million Canadians do not have access to not just a primary care physician, but to primary care. What would I do? I would, as a federal government, I'd introduce a primary health care guarantee with, let's say, $10 billion behind it over the next 5 years. And I'd negotiate with the provinces, some of whom are doing like BC's doing a good job of sucking doctors out of Saskatchewan. 11% of family docs wound up primarily going to BC and Ontario because of what BC is now doing to make it easier for physicians to practice good medicine and in a group environment. But let's think about a primary health care guarantee. Those provinces that get between now and 5 years from now, from X number of residents not having access to get to that 100% or close to it, they get the money. But the point is current state, future state, and then start looking at how you engage Canadians. I mean, how does this happen? Citizen engagement. Canadians demanding it of their governments, federally and provincially. And this is still the majority, the 67, 2/3 of Canadians who still think Medicare is a defining quality of being Canadian. But they're not happy with having to opt out. They feel guilty about opting out. I can afford it. So, I'm going to go get that hip surgery and jump to the front of the queue. Canadians that do that, I guarantee, I'm thinking, don't feel good about it. So how do we help Canadians feel better about the healthcare system being there for them? Well, we need to engage them, listen to them, and then have politicians held to account electorally. How do we make it a ballot issue? in the next federal election?
Great question.
How do we make it a
We
balance?
keep talking about it being rock bottom, like we've hit, catastrophe, the system's collapsing. Like, what does rock
our
bottom
system.
look like?
No, but I'm gonna check. Our system is not collapsing. When you're sick, we're quick and we're good. I mean, we hear a lot about the folks that didn't get the elective surgery, in the 6 months or less. But you know what? For every one of those examples, I've heard of 10 examples of where, my mom had a stroke. And within 4 hours, she had the TPA or whatever the new version of that is within the first 4 hours. And then she was transported, like a queen, she said, in the Stars helicopter from Regina to Saskatoon. Saskatoon had a world-class, center of excellence in stroke, determined that she didn't have any follow-up ones. And then she said, they rode me back in the back of an old ambulance on the road, Bill. but you know what? I just visited her. She's turning 90. That was 2 years ago. So the system, when you're, in the majority of cases where you're sick, we have such great doctors, nurses, and others, and the team that it's not broken. It just needs some structural reforms that are meaningful. How doctors are paid, how hospitals are paid, how we view doctors not as cost centers but as value centers and service centers. Doctors historically, health economists have said, hey, the way to control costs in this system is to have fewer Jordans, because Jordans write the scripts, Jordans do the admissions. So if we want to bend the cost curve, we need to control the number of docs. Here's a stat. We rank, I think, 32 out of 38 OECD countries in terms of number of doctors per capita. And is that accidental? No. That's over the years, control the number of docs. And so, I'm not saying that's quadruple the medical school enrollment. I'm just saying let's look at more systematically and more, more at a system level, how physicians are part of getting us from where we are to where we need to be in terms of providing the health that they want and that their patients need.
So I guess, are things progressing in the right direction then? Like, we've got, I don't know, it's kind of funny. Like, I spend a lot of hours every week talking to my patients with mental health concerns about, okay, well, we got to stop with the pessimism and flip the mentality to the glass is half full. But in the healthcare system, okay, maybe the system isn't collapsing. Maybe we aren't literally on the brink, but maybe the advocacy bodies and getting that message out there of, okay, we need to reform. Maybe that is working exactly as intended without being at the literal bottom.
Well, as a former CEO of, I guess, 3 different national organizations, Heart and Stroke Canada, CMA, and then what we used to call the Canadian Hospital Association until we declared hospitals no longer legally exist in places like Alberta. The first question I always asked as a CEO is, what can we do? What's within our locus of control? Or I was fond of, there's this, if you can imagine, there's this criticality matrix where you've got, need on the one axis, number of Canadians that would be affected by whatever policy you're looking at, and my ability or our ability as an organization on our own and working with others to actually make a difference. The influence factor. I would always ask, what is it we can do first and foremost on our own or working with others? The CMA, what can we do on our own or working with others to deal with wait times? And we formed the Wait Time Alliance. And we adduced the evidence in terms of maximally accepted, clinically indicated wait times for cardiac surgery, for coronary bypass surgery, for lens implants, for hips, knees, and for cancer therapy. And what was the 5th one? Oh, diagnostic imaging. Did it make a difference? Yes. The federal government Harper introduced, to his credit, the wait time guarantee. And did wait times come down in those 5 areas? Yes. Did they stay down? No. Because it was kind of one and done. Again, there was no ongoing sort of invigilation. There was no ongoing sort of stewardship to ensure that they stayed down. So, do I think the system can be fixed? Of course. I wouldn't be having this conversation with you. I'm 70 years old. I'd be going riding. I'd be out doing something else. But I still believe that I don't have any control anymore, but I still have some influence. And whatever influence I might have, Jordan, to help our healthcare system get to a better place, then I'm happy to kind of use up whatever residual political capital I might have.
Well, I like what you're saying, not just the applying accountability to everybody else, but also, when you point a finger, you've got three more pointed right back at you, right? It's like
That's
bringing it
exactly
in-house at the same time. I think we probably could use a substantial amount more of that in probably medicine, but also the other facets of health as well.
Well, if I can just add two other things that I just before we maybe conclude here. One is we've written recently. You mentioned we've co-written a couple of textbooks on health leadership. One of the things that we haven't paid enough attention to is resilience and how you can build resilience as an individual and as an organization. And so, for example, organizations can build resiliency by having a lot of simulations. What happens if we have another COVID? These kinds of things where you simulate, and then when it actually happens, you can snap back rather than just snap. Same with the individuals. Leadership, mindfulness, going outside your comfort zone, being encouraged by your mentor, your sponsor, your supporters to take on that new job, and with knowing that they're going to be there to help you out. So the more we can do to build organizational and individual resilience, the more we go from just surviving to actually thriving coming out of these things. So when people are too pessimistic, I tell them about that resilience is like a muscle. The more you work it, the stronger you get.
That's key.
The other thing is leadership. I mean, what kind of leadership? Compassionate leadership, authentic leadership. You got to be true to yourself, or nobody's going to follow you. And so, and above all, if you, who wrote the book, How the Almighty Fall? It's getting to, it's Collins again. And you don't need to read the book, because when he looked at BlackBerry and all these organizations and individuals who were really riding high and then boom, came back down, he came to one conclusion, and that was hubris is what brings down individual leaders and organizations. So a good dose of humility as a leader goes a very long way. Saying, what, I don't know. But maybe we go and find out by broadening our sort of reach in terms of working with others. So collaborative leadership, authentic leadership, compassionate leadership, and leadership based on a good dose of humility.
Well, probably a good spot to wrap up there. Before we end, what's your one main health tip? How do you keep yourself going, mind and body? How do you do it?
Well, since I've retired, or what I like to call rewired, I try to. So, what can I do to continue to grow, to learn, to contribute, and to feel valued? Okay, so doing this with you gives me some sense that I'm valued, that the opinions matter. I volunteer. I'm on my condo board as well, so that's another way to kind of continue to grow and to learn, and because that's a board that I've never experienced before. So that would be my advice to others. Continue to learn, grow, contribute, and hopefully feel valued.
Having a cause. I love it. Awesome. Well, Bill Thal, thank you so much for joining us today. Really appreciate the insights. That was amazing.
Great to be with you, Jordan, and hope to learn more about what you and your colleagues are doing at Cherry Health.
Thank you.
Okay. Take care.
Thank you for joining us this week on Leaders in Healthcare. If you enjoyed this episode, please like, subscribe, or leave a comment. And if you found this episode helpful, Don't forget to share it with your network.